I think now we move on because time I think is less. We have still a couple of talks in surgical session, and we request Satish again to please come back and tell us about tips in PDR, surgical tips.
Thank you, sir. And now I'm going to talk about the few surgical tips in proliferative diabetic retinopathy. I think the basic surgical goal when we operate a patient with proliferative diabetic retinopathy is clearing of the vitreous cavity. That is any vitreous hemorrhage which is there. We need to clear the vitreous cavity and relief of traction. Relief of traction of the around the fibrovascular proliferation, or relief of removal of the fibrovascular proliferations, and relief of traction on the retina. Control of bleeders, and it is very important, and not to forget an adequate laser at the end of the surgery. It's extremely important. It is extremely important for us. Hello. So so this is a video which is showing that, these are the 4 important tips here. Whenever you are trying to do a vitrectomy, try to avoid suction to induce a PVD. Try to avoid a suction to induce a PVD. Avoid traction around the fibrovascular proliferation. It is going to bleed, and as soon as it bleeds, try to cauterize as quickly as possible so that the view will not be extremely good for that particular patient. And do an adequate laser. Do an adequate laser for this particular at the end of the surgery, and that is extremely important. Now, in the second video this was a one-eyed patient who had a vitreous hemorrhage and non-resolving, which we had done a vitrectomy, and at the end of the surgery, we realized that there was a polyp which was there on the more on the nasal side, and a couple of the polyps had got a very broad attachments, and so it is not always necessary that we should remove every fibrovascular proliferation we see. So here we have segmented the polyps, identified that there was no evidence of any traction left behind. So we trimmed that particular polyps, and we found a bit of fluid in the macula, and so we injected a drop of IVTA, put in a fluid gas exchange, and closed that particular case. So the tip is that if you identify a CME, I think you should put a drop of IVTA at the end of the surgery. There's nothing wrong with it. As we all know, when we deal with this was another patient where we had a bad vitreous hemorrhage, and he had a peripapillary traction basically. So the key to identifying the membrane here is to go under the second membrane. So if you want to remove this particular massive proliferation which is extending from the disc and onto the nasal side, you can see that at that particular point, you need to identify the second membrane. And I think that is the key to when we are trying to do a surgery for PDR. Now here in this particular patient, you can see that after we cleared the hemorrhage, the patient did have some amount of subretinal as well as sub-RP heme. Fortunately, it is just stopping very close to the fovea. I'm trying to identify a second membrane which is getting onto the surface of the macula. We can actually see that. So I'm removing that particular traction from the surface of the macula using an engripping forceps. Now the question here is, this is a $1 million question in which every surgeon faces on the table. Should I remove this particular, relieve this particular large NVD which is sitting on the disc and causing a gross traction? Yes, I decided to pull this up, and so we go ahead and try to pull out this particular thing, and we do expect a kind of a little amount of bleed. But I always believe that this relief of the peripapillary traction is also quite important in a few cases, and so this is what I did, a kind of a delamination. And you need not really worry much about the bleeding part of it, because there are 3 types of bleed which occur from the disc. One is a capillary ooze, one is a venous ooze, and one is an arterial ooze, and of which all of us know that the arterial ooze is the most difficult one to control. So the simple trick for us to follow is, you can raise the intraocular pressure, because majority of the capillary bleeds and the majority of the venous bleed do respond to your raise of IOP. So once you finish off, once still it is still oozing from the disc, you can just wait for a certain period of time, finish off the laser in the periphery. At the end of the surgery, you really don't have to remove the entire clot sitting on the disc. You can leave behind a small clot on the surface of the disc and make sure that this particular clot is a non-oozing clot. That's exactly what we need to do. The next important tips for our surgery is, as much as possible, we need to relieve the traction along the arcades. And if you don't relieve the traction along the arcades, then I think we'll land up in a problem. And sometimes it is very difficult for us to identify the plane. And this is another trick which I use. I use the end-gripping forces to go on the disc and gently pull it up. I don't pull it up into the mid-vitreous cavity, slightly above, to create a plane. Once I created a plane with the help of the cutter, you can relieve the traction which is there between the 2 arcades, the lower and the upper arcade. And from here onwards, and you can slowly get onto the second membrane. See, you can see on the inferior temporal side where we can actually see we are able to go through the second membrane and try to peel it off. Now, at one particular point of time, one of the important place where I use scissors is if there are large thumbnails. The membrane is attached with a larger thumbnail like this, where I have used a scissor to cut off that particular thumbnails. And scissors can also be used as a spatula. Often I do not go directly into a bimanual surgery right at the outset itself, and I reserve bimanual surgery for extremely bad cases. But majority of the cases I can get away with a unimanual dissection. And you can see, you can even use the scissors just like a spatula and try to peel off those membranes. One of the biggest advantages with the scissors is the cutting action of the scissors itself acts as a bit of a hemostasis. It also provides a little amount of hemostasis, unlike what you use when you use the cutting action of a cutter. So scissors can also be used as a multitasking agent. So just the take-home message, and for these 4 slides or 4 surgical videos which I've shown is, avoid suction to induce PVD, just like what you do for a macular hole surgery or what we do for a regular retinal detachment surgery. Especially if it is around a fibrovascular polyp, you should avoid a traction on it because it's going to bleed terribly. Or when you're trying to provide when you're trying to force a traction onto the fibrovascular proliferations, in addition to bleeding, you may convert a tractional retinal detachment into with a combined retinal detachment by creating a break, which will make the further dissection even bad. Please, at the end of the surgery, do not forget to finish off the laser, because nowadays a lot of people try to hurry up their finish off and put an endo laser, put a tamponade and just close it off. I think adequate laser is a must at the end of our surgery. And relieve the peripapillary traction. Relieve the peripapillary traction and arcade traction to the extent possible. And not all FEPs need to be removed. And on the disc, you can leave a fair amount of non-oozing clot on the surface of the disc, which will also act as a tamponade. And scissors can also be used as multitasking. Thank you for your patient hearing.
Thank you, sir.